Dr. Saad, and as you know, in previous section of video, we recorded about the peripheral nervous system. As you know, we are recording series of lecture for pharmacists who are going to appear for international equivalency exams. These videos are going to be helpful for them for their preparation, and we will provide them a key points through which examiner can set a paper. So we was discussing nervous system, and recently we finished about the peripheral nervous system, in which we discussed in a detail about the autonomic nervous system. So now we are going to start about the central nervous system, that is the second major part of the nervous system. So without wasting more time, let's start our topic, that is the central nervous system. As you know, central nervous system, its two major components, that is the brain and spinal cord. Spinal cord is divided into three major types, that is the cervical region and thoracic region and lumbar region and spinal nerves. From here, efferent and efferent releases, and as we discussed remaining section in ANS and somatic nervous system. So let's move back towards our main second part of central nervous system, that is the brain. As long as the anatomy of brain is concerned, it contains six major components, that is about the cerebellum, diencephalon, pons, medulla oblongata, and midbrain. As you know, as you know that the cerebellum is divided into two major hemispheres, that is the right hemisphere and the left hemisphere, and each hemisphere is further divided into four lobes, that is the frontal lobe, parietal lobe, occipital lobe, and temporal lobe. These all brains has their different functioning, and each functioning is being carried out by a specific unit, that is known as brain and nephron. That is known as nephron and glia. Let me tell you once again in detail that cellular organization of brain. These are two cells, which is the basic, controls all the functioning of brain and play a key role in coordination, and that is the neuron and glia cells. Glia cells play a role in supporting neurons related supply, its protection, its myelin formation, anything. A glia cell actually has only supportive role. Major cell, that plays a very key role, and about which we will discuss in detail, and that cells through which we will modify their transmitters for carry out our pharmacological effect is neuron cells. And as you know, the peripheral neurons and central neurons are a little bit different. Like in central neuron, there is a cell body, and upper units known as the dendroids, and lower part that is known as axon. And one cell body's axon, at the point at which it terminates, it's like closer to the next neurons dendroids. The point here where these axon terminal and the dendroid terminal meet is known as the synapse. It's almost similar as it was we discussed about it in the peripheral nervous system. As I told you about there's a lobe in the brain, as there's a two hemisphere in the brain. These two hemispheres are joined by the corpus callosum. This is the point from which these two hemispheres are joined, through which the nerve cell transmit information from one section of brain to the other section of brain to carry on the normal activity of our body, and normal thinking process and coordination process of our body. So, as when you see the dissection of brain, you will find about two major visible component, that is the gray matter and the white matter. Gray matter is a point where mostly cell body is stationed, and white matter is a point where the axon terminal is placed to. This is an arrangement section relevant to arrangement. So as long as we talk about the arrangement pattern of nephron in the brain and in the central nervous system, that is either in the form of a cluster or it will be in the form of the bundle. So this was all about some introduction about the nephron and anatomy of brain and spinal cord and sections. So let's discuss about some physiological arrangement of nephron. There are two main systems through which these nephrons are controlled. This nephron are organized in the brain. One of them is known as hierarchical system, and second one is known as the diffused or non-specific neural system. As long as the hierarchical system is concerned, it is further subdivided into two major types, that is the projection neuron or local circuit neuron. As name indicates, this local circuit neuron keeps their activity within a specific circuit and transmit information within that circuit. And on the other hand, projection neuron, as name tells, that it projects information from one section of brain to the other section of brain. This is all about the hierarchical division of the nervous system. Second system is the diffuse system. It is an unorganized and diffuse system. It's actually organized, but according to for your convenience to tell you about it, it's an scattered system in which brain use acetylcholine, norepinephrine, dopamine, and serotonin as as a neurotransmitter in a diffusive way to coordinate among the different sections of the brain and to carry out normal physiological activity. So this was all about the major arrangement. As long as you know the transmitters are concerned of the central nervous system, I want to tell you about the list of transmitters which play a distinct role to carry out its specific function. Still, research are going on, but a lot of transmitter has been identified, and we are modulating them for our physiological activity. Out of these transmitters are dopamine, norepinephrine, gamma aminobutyric acid, commonly known as gamma, and glutamate and glycine and histamine, opiate, oxygen, endocarbinol are these type of the neurotransmitters which is being used for the transmission of information in the central nervous system. So this was all about the introduction of brain and its anatomy and it's a little bit physiological units. So let's talk about our first topic, that is about we will start discussing the points, and today we will discuss about some one to 2 points about the Alzheimer's disease, and remaining points will be discussed relevant to the gamma aminobutyric acid is known as gamma receptors, and its role we will use specifically for the insomnia, for the anxiety disorders, and for the these are the main two components. We will use its role for the management of sedative and hypnotic effects, and sleep disturbances can also be managed by this receptor. We will discuss it. So let's talk about our first point, that is about the Alzheimer's disease. And as you know, the Alzheimer's disease is a disease where acetylcholine level drops in that section of brain which controls the memory as well as language. So it is being managed by increasing the acetylcholine level by the inhibiting acetylcholine esterase, and the drug which is used for this purpose is known as donepezil. Its dose is 10 mg per day. This is the management method for the Alzheimer's disease. Its second point is about the phenobarbital and chloramphenicol interaction. So as you know, the phenobarbital is a barbiturates. It play a role through the GABA receptors. Just hold for 1 minute. I would like to introduce this GABA receptor. Gamma aminobutyric acids it's also known as gamma aminobutyric acids. It has two subunits, that is the GABA A and GABA B. GABA A receptors is an ion you can say ligand gated ion channel receptors. Its simple meaning is that when ligand binds, it will open the channel, and when ligand removes, it will close the channel. This is a simple one-step approach of controlling this channel. Second one is the GABA B. It is also known as metabotropic receptors or G protein coupled receptors. It transmits information through two steps. Number one is through the G protein, and through the when ligand binds, then it will activate the secondary messenger through trimeric structure. This is known as alpha beta gamma structure, through which it will either control the release of calcium and potassium. When GABA is actually an inhibitory receptor, it slows down the brain's activity. That's why it is basically used for the management of the anxiety and hypnotic effects and sleep disturbances. So we will modulate, as you know, we use basically benzodiazepine and sometime barbiturates to control this. That is play an inhibitory role for they play so that use this GABA receptor to carry out their actions. So similarly, we also use the buspirone, which is the which is the I will tell you later about this drug. Let's talk about the interaction about the point number 2 is the interaction about the benzodiazepine, phenobarbital and chloramphenicol. When these two drug combines together, it ultimately precipitates barbituric acid, which is actually act as an barbiturates, so it will enhance the sedative effects. Third point is about the zolpidem. Zolpidem, its dose is about 2.5 mg to 10 mg OD. So it's a new GABA agent. It's a fast acting and short duration of action. Point number four is about the thiopental. As you know that thiopental is a lipid soluble drug. It crosses blood brain barrier, and this is all about this point. Point number five, our next point is about the again timazepine. Timazepine, I will keep on telling you side by side the doses because it will keep in you, it will remain in your mind. Maybe it can be asked in the exam. Timazepine is also known as benzodiazepine. Its dose is 7.5 mg to 30 mg. It is metabolized into liver in an inactive metabolite and excreted in urine. So that's why it is activated outside of the liver into the oxazepam and it performs its hypnotic activity. Point number seven is about the sleeping aids. As you know that sleeping aids, there are few chemical which play a role for the management of sleep. That is the we use basically melatonin, diphenhydramine, and oxylamine. And there is a one product that is found, that one chemical that is found in the milk that is known. Its name is tryptophan. Tryptophan. It's a chemical which play a role in inducing this sleep. It are also known as sleeping aids. Point number eight is about the short-acting benzodiazepines. Its example is alprazolam. It is given in the dose of 0.25 mg, 0.25 mg to 0.5 mg, either BD or TDS. Next is the lorazepam. Its dose is 1 to 2 mg, OD or BD. Third is the temazepam. Its dose is 7.5 mg to 30 mg. Fourth is oxazepam. Its dose is 15 to 30 mg. We can say you exactly 50 to 30 mg. And zolpidem, its dose is about 2.5 mg to 10 mg. So alprazolam, lorazepam, tomazepam, oxazepam, zolpidem. This is used specifically as a short acting. These are all are example of the short acting benzodiazepine. It is specifically used in elderly for the management of hypnotic effects and sedative effects. Point number nine is about the metabolite of phenobarbital. As you know, phenobarbital, its dose is 50 to 30 mg. TDS can be given TDS 3 times per day. It is metabolized by primardone and it metabolite in liver and excreted in urine. There is a chances of its precipitation because it's a basic, so there's chances of its precipitation in urine. So this was all about this point number nine. Point number 10 is about the colloidal hydrate. It's also an hypnotic agent. Its dose is 3 to 2 gram per day. And point number 11 is about the nitazepam. Its half-life is 30 hours. As you know, it should be avoided in elder patient because its accumulation causes fracture, and because its accumulation causes fracture because of its daytime sedative effects, and it has very long half-life. So rather than this, we can recommend oxazepam, whose dose is 50 to 30 mg TDS, or we can use lorazepam, whose dose is 1 to 2 mg OD, and its half-life is 10 to 20 hours. So nitazolam should be avoided in elders because it causes daytime sedative effects. It was all about point number 11. Point number 10, point number 12 is about the mechanism of GABA. As I told you, that GABA A activates it increase ocular channel, and similarly GABA B when activates through secondary messenger, it at presynaptic it inhibits the calcium secretion, and at postsynaptic membrane it increases the potassium secretion. So through this way it will play its role as it's a calming neurotransmitter found in brain and spinal cord. Point number 13 is about the lorazepam. Again, its dose, you know, that 1 to 2 mg per day, and it's most suitable and night sedative and anxiety management. It is as you know, lorazepam is the most suitable sedative and anxiolytic management for night. So you can recommend it, and specifically for a patient who has kidney, who are with or without kidney cirrhosis, because over sedative due to accumulation, it doesn't cause over sedation due to its accumulation. That's why it is most suitable for patient who has a liver impairment, a liver cirrhosis patient. It's most suitable for them for the sedative and hypnotic effect for the night, or you can say for the management of anxiety. Lorazepam is a most suitable effect, most suitable option. Point number 14 is about the flumazepam. Flumazepam is a long acting and it causes hangover effect, and that's why uh, flumazepam is the most yes, it's correctly, it causes a long lasting, it causes hangover effect. So it is because it's a long duration of action, mostly benzodiazepine causes side effect. Exactly. So this point just simply tell you about the flurazepam. Its half life is about 40 to 100 hours, so it should be avoided because it causes hangover effect. As you know, hangover effect is a patient feels sleep disturbances, and even he can't sleep properly. So this was all about lumazepam. Point number 15 is about drug induced neonatal jaundice. It's a specific disease in which new babies bilirubin level increases due to introduction of another drug. So there was two method to manage it. First method was the exchange transfusion. It is hazardous method, so it was a traditional method. So it is being replaced with the use of barbiturates. It is given even after delivery. Immediate after delivery, it is given with a dose of 5 mg 3 times per day for 3 to 5 days until barbiturates level until bilirubin level drops below uh, 10 gram per deciliter. So this is this is one of the options for management of neonatal jaundice bilirubin level. Question is this: how it do so? It has two method for it for carry out this activity. Number one is through the stimulation of liver metabolizing enzymes, which increase the glucuronization and increase the production of conjugated bilirubin, which ultimately excrete out of the body and can't reabsorb. Second method is through the increase the production of bilirubin binding Y protein, which conjugates with which ultimately help in the conjugation of bilirubin level. As you know, the conjugated form of bilirubin can't be reabsorbed, and in this way bilirubin level is controlled. But remember, once this treatment is failure, then there must be required completely stopping this drug. Simply, we can say that complete discontinuation is required, or you can say permanently stop this drug once treatment is failed from this. So this was all about the management of drug-induced neonatal jaundice by the use of benzodiazepine barbiturates. Point number 16, that is about the diazepam has long duration of action than timazepam. It's just a comparison of duration of action. As you know, that's why when temazepam is given 7.5 mg to 30 mg, and diazepam is given 5 mg BD, and diazepam has a longer duration of action than that of the temazepam. Point number 18 is about the if you want to manage a patient's anxiety, but you don't want anticonvulsant effect or muscle relaxant effect or sedative effect, then then there is a buspirone is one of the best option for this, and its dose is 5 to 10 mg BD. This is all about point number 19. Next point, it's about the barbiturates, and point number, it's about the barbiturates. There are some about three types of barbiturates. That is the short acting, long acting, and intermediate acting. As you know, long acting barbiturates example is the phenobarbital. It's again, I want to revise this dose. It's about 15 to 30 mg TDS, and intermediate acting is about embobarbital and butobarbital, and short acting is about secobarbital, and its dose is about 100 to 200 mg. And ultra short acting is about thiopental. These are the example of some different barbiturates with respect to their duration of actions. As you know that exactly this point about the buspirone has already been discussed in this video. So let's talk about our